Any question? Any quick?
Now here, of course, yeah. Thank you for. It was really amazing. Now, of course, in Sri Lanka, we use only two things: dexamethasone and heparin. Nothing else. That's a recommendation by the Sri Lanka based on, I think, WHO. And of course, tocilizumab when they're really bad patient, when they're really severely ill patient. Other thing is, now we do what you call high exercise. We do give some exertional hypoxia. We ask them to ask the patient to sit up and down, and if there is a drop of oxygen, again we do consider steroid and heparin. So do you do that kind of exercise or exertional induced hypoxia?
I do standard 6-minute walk. Every hour, every 2 hours, every 4 hours, whatever time they do, I want to see that 6-minute walk done. I also want to see proning done. The guy who went up from 60 to 96 in the same day, he had recovered within an hour and a half of just doing proning, he'd come back to 80. Okay, and then since it was 6 a.m. and I saw him only at 9 a.m., he had recovered to 80, 82 by the time I'd seen him. And he recovered to 96 after I gave him the enoxaparin and I made him do proning literally the whole day. On that 7, 8, 9, 10 days, if it's an acute thing, when I'm starting enoxaparin, or what do you call it, what is heparin in your case, I use low molecular weight heparin here. So if you're starting on that, then make sure that the patient is not sleeping on the back. I make the patient walk that whole night. If they sleep on the back, the blood is going to clot in the lungs. So they either sleep on the stomach or on the side, or they don't sleep that night. So one night, if they sacrifice, they will be safe. I mean, they can recover. I've had patients at 80, 81, 79. I've said no sleep that night. The next morning, they're 92. And it gives the drugs time to actually block that clotting. So that's some of the tips I can give you. Okay. Proning is very important. Yeah. I would suggest you consider colchicine, sir. I mean, that's something that's a fantastic anti-inflammatory, and I can give you a write-up as to why I use it. I mean, toxination.
Yeah.
Okay.
So colchicine, do you see immediate response to colchicine?
Absolutely. You start stopping the inflammation and the potential to clot right up front when you give it. So I normally give a 1.5 milligram dosage for the day. I've tried everything up to 6 milligrams, 3 milligrams. I've tried half a milligram. The sweet spot that I found is 1.5 milligram, 2 in the morning, 1 at night. Kind of works really well for me in the telemedicine setting. You could even do 2 and 2. So you can do 1 milligram and 1 milligram at night. So again, depending on severity of the disease, you can do that. Somebody had a question about COVID pneumonia. One second, let me go back to that question. Can the damage caused to lung parenchyma reverse completely? Absolutely can reverse. I've taken a patient 15 by 25 down to 0 in 30 days. But my enoxaparin usage was aggressive. Twice a day, 60 milligrams, once for 5 days, then once a day for 10 days. That patient was down to 0 in 30 days. So absolutely, the goal is to have the patient with no lung damage. And this was a 55-year-old lady. So it's not an old lady, not a young lady, 55-year-old non-diabetic. So that's something that we will take. Okay. What other question do you have? Let's take.
How do you do the, prone position? Do you change? There are, I think, every 30 minutes you change the position, or do you follow a different kind of?
It's the same. There's a couple of videos that are doing the round. One is a pretty stout guy from the U.S., from Texas or somewhere, who's on his elbows and knees and all that, doing proning. That's very useful. And I have an Indian person also who did a video for me to show proning. It's a great way of doing the movement of the blood in the lungs. Don't allow the blood in the lungs to stagnate. If it stagnates, it's clot. Okay.
How often do you do that in the prone position?
3 times a day, 4 times a day, 5 times a day, depending on how bad the patient is and how much the patient is willing to work with you. The point is, you have to make an impression on the patient. If you want to live, you don't want to die, you don't want to go to ICU, do this. This will help. And it helps a lot. I mean, there are people who initially hesitate, no, I can't do it, I'm too weak, and we make them do it. We literally show them how to do it, and they recover pretty well. So proning is an easy thing to do. It's a manual maneuver, and it's very easy to do. I mean, that's something which is non-pharmacological. It's something that's physical, and do it. Yeah, Dr. Sundaresh.
There's a question, I think. Vishnu, is there a question? I have a question anyway.
Yeah, it was answered.
Okay.
Yeah, you can go ahead with your question. Yeah.
Yeah, other thing is now the day. Now, when do you see exactly a particular day the shift happens? We call it initial viral phase to the immune phase. So is there a particular day you are just really concerned, or until particular day they can be at home? So what is the day, or it differs from patient to patient?
The normal standard days are week 1, week 2. Okay, so week 1 is, I divide week 1 into day 1 to 4 and then 5 to 7. Okay, so 1 to 4 is easy to manage them at home. You don't even have to do anything if they come early. They come 5, 6, 7, you may have a problem, but again, you can manage them at home. The problem is when they get to 8, 9, 10. 8 is when they start clotting. Night of the 7th and morning of the 8th, they start clotting. When they start clotting, you're in trouble. And that's when you got to be really cognizant of the fact that they are going to start clotting on day 8. This is a 14-day disease. Okay, so 8, 9, 10, if they survive it nicely with no problems, even thing, no issues with the oximeter reading, no breathlessness, no cough, no fever. 11 to 14 is a smooth ride. So it's a coast. So it's not a problem. Okay, so if you play that 1 week, 2 week, it's great. Then of course, I look at the balance 16 days of the month. So for me, acute COVID is 30 days. Okay, this is a 30-day full treatment. So unless the patient lands up in the hospital or I'm forced to admit a patient, usually I keep people at home. I treat them at home and do whatever I need to do for them at home. The difference is if they can get oxygen at home, I can do most of it what they can do in the hospital, including IV intravenous administration. I can do a lot of stuff in the home setting. Okay, the hospital is when you need to get other specialties involved, other things are involved, and you really need more intense care for the patient. That probably day 9 or 10 they'll get admitted, or they come to me straight away with a 20. I normally admit 20 by 25 and above, 80% lung, 75% and upwards. I admit. I try not to keep these people at home. It's a lot of stress keeping them at home. Okay. However, I also learned one thing: when there were no beds, I was able to manage these guys very well at home without any issues, and I was able to reverse them. So when we had that major surge, April and May, it was to my benefit to try new things and try an aggressive method and kind of get what I wanted to get. So it's all dependent on what the current situation is. Okay.
That's another question, I think, Vishnu.
Question, yeah. Commander asked, how long do they stay in prone position per cycle? So you mentioned earlier that there are about 4 to 5 cycles per day.
Some patients are very weak. They can't really do it. They do it, even if you do it for 5 minutes, is better than doing it for not doing it. Okay, so ideally you want them to do a 30-minute cycle, 4 times a day. But even if they can do 5-7 minutes, I'm happy with that. As long as they're not lying on the bed, as long as they're up and about, as long as they're moving during the day and during the night, especially on day 8, 9, and 10, they will recover nicely. Okay, so that's regarding the proning position. Let's talk about percentage of patients that underwent intubation. Anybody who comes in at 20 by 25 or 23 by 25, and the oxygen saturation are very low, will end up with intubation. But in my case, since primarily 90% of my cases are telemedicine, and my results have been outstanding. I'm not sure how many of it. I'll have to go back and look at how many of the 16 people ended up with intubation. Usually they end up with they die because of a heart attack. So they die because of clotting. Okay, because we have a mismatch on the dosage being given in the hospital and being given here. So that twice a day, 60 milligrams or 1 milligram per kilogram body weight is very important to calculate and give. And again, timing is important. A lot of things are important when you're looking at that. Yeah. Despite not having comorbidity, or despite having comorbidity, young patients die because of carelessness. Carelessness and callousness. I call it misdiagnosis and mismanagement. Okay. So young patients should not die. I've had a 35-year-old die. She came to me with a history of 3 days fever. Sat with me right behind where I'm sitting, right behind me. She sat with me. I had my arms around her. I said, Mary, don't worry, we'll take care of you. Her oxymeter reading was 85 when she came to me. I brought her up to 90, sent her home, 2 hours made her wait, sent her home, had her go up to 92, 93. A report came in, HRCD, severity score report came in at 20 by 25. At 10:30 at night, she's safer in the hospital. I put her in the hospital. She died a day and a half later. And I don't know why she died, but she died of a sudden heart attack. I'm guessing it is due to the mismatch of the enoxaparin anti-clotting regimen. You guys got to be careful on using enoxaparin. This is an active clotting disease. Do not go with prophylactic DVT regimen. It will not work. Okay, especially in young people or old people, it doesn't matter. Use the therapeutic dosage of enoxaparin. It'll make a big difference to what your success rates are. Okay, comorbidity, diabetes. All my deaths were diabetes. I can't help it. I mean, I've tried my best. I ended up bringing in a specialist to look after the diabetes side so I could focus on COVID. I bring in somebody to manage the sugars literally on a meal by meal basis. And that made a difference to the success rates in diabetics that I had. And it also allowed me to focus just on the pure COVID management, okay? A dose of aspirin, I don't give aspirin, I give clopidogrel, it's 75 milligrams. I have now started a new thing of doing the loading dose. So I give 4 tablets of 75 milligrams, about 300 milligram day 1, and then 75 milligrams per day after that, okay? Does it combine with enoxaparin high dose? No, I stop clopidogrel and continue with enoxaparin. I don't do both. I've never tried to combine the two. When to start antiplatelets, you start day 1, the patient comes to you, ideally day 1, 2, 3, 4, 5, 6. Don't wait till day 9 or 10, then it's too late. If they come to me day 9 or 10 with oximeter readings below 85, I'm starting enoxaparin. I'm starting probably even dexamethasone injections. Intramuscular, I don't use IV, I use the intramuscular injections and go from there. So these are some of the things I do. Yeah. Questions, Dr. Vishnu?
Yeah. Why do you select clopidogrel than the aspirin? Any reason?
Yeah. Initially, in the first 200 cases, I used to do the CBCs upfront and then in the second week. And I saw a bounce back of platelets. Platelets usually in the first week will be lower than normal, lower than 150. So if they are at, let's say they're 120, 130, I have seen as low as 70,000. When in the second week, you see it going up, it goes above 450,000. And I've seen as high as 750,000. So that led me to kind of evaluate an anti-platelet strategy rather than just a blood thinner strategy. Okay. Hope I answered your question, Dr. Sundarshan.
Yeah. And HRCT, of course, we hear, of course, it's difficult to get. CT is available, but it's difficult to get the CT done. So, do you think it really changes the management, or do you think what is your suggestion when you can't get the CT done frequently? We may, but not.
I don't get it done frequently. I get 1 CT done. Okay, I get 1 CT done day 7 or 8, and then I base a lot of my second week management on that CT. Okay, if the score is say 4 by 25, it doesn't matter. Nothing's going to happen to the patient. She's fine. He or she is going to be fine. But let's say it's 10 by 25. Okay, you're going to have. You can expect accelerated clotting. You can expect that patient by day 9 or 10 to be at 20 or 23. So you want to really start the enoxaparin. Anything above 10. So anything above 10, I'm starting on enoxaparin. I may even start on dexamethasone. I may wait a day and start on dexamethasone. Again, it's all dependent on the patient's symptoms, oximeter readings. I've had normal oximeter reading, okay? Oxygen saturation of 96. HRCD shows me 15 by 25. Okay, start on enoxaparin, start on dexamethasone, start everything you have to. Clobber the patient, hit the patient really hard with what you have. It'll make a difference. Okay, sorry, I'm using very strong words here, but you got to get aggressive if you want to save patients. Okay, bleeding complication, no. Following enoxaparin, no. I've never had a bleeding complication. I probably use enoxaparin about 30–40% of my cases. I don't have a final data point, but I can look up and give you an answer sometime. But you know, this is active clotting. Here, the blood clotting in the day 7, 8, 9, 10 is very, very active. So please ensure you're using the right dosage to do it. Bleeding, no. Now, I have a question about what happens if you have to do a procedure like intubation. That time, if you're going into intubation, it's too late for the patient anyway. So, you know, those are something that between a telemedicine guy and a hospital guy will change, will be different, okay? Ideal time for HRCD is probably day 7 or 8. If a fever starts or fever is recurring or continuing, do a HRCD. That will be due to inflammation. This is not a bacterial infection. If you notice, I do not talk about antibiotics. I do not use any of the antibiotics. I've used doxycycline, I've used azithromycin in the first cases. I have stopped using them in a few thousand of cases. I've stopped using any antibiotics. Antibiotics are used in the hospital setting mainly to prevent and treat hospital-based infections, not the home-based infection. Home-based is an inflammation, so you really don't need an antibiotic. I see 3 antibiotics written by family practitioner, not required, you know. Oxygen support, yeah. If you have oximeter readings of less than 90, try and get oxygen support. If you have, I mean, my standard is if it's below 85, they have to get oxygen. I do not want to. So we try to get oxygen, either home oxygen or hospital-based oxygen. Like I said earlier, my strategy is to admit people below 85 in oxygen saturation rates. I'll keep them at home if I can't get a bed, and I will ask for an oxygen concentrator, cylinder, something. In the peak, in the middle April peak time in Delhi and Chennai and all the other places, when we couldn't get beds, I used to get 10, 12 patients at night, usually between 9 in the night and 11, 12, 1 o'clock in the morning, and then try to manage them, tide them over, bring them back. And so, yeah, I've learned to use a lot of things. Yeah, so. What's the other thing? I'm trying to think of what are the other questions here. Yeah.
One question I can ask from here, the chat box. What is the role of convalescent plasma in treating COVID-19 patients?
What's the role of what?
Convalescent plasma. Convalescent plasma.
I've never used convalescent plasma. I don't believe in it. It doesn't work. The data, the clinical trial data has said it doesn't work. So people use it. Our doctors use it. Hospitals have used it, but they've used it in patients who have never survived, who haven't survived. So I don't think I've seen anybody survive after convalescent plasma. Okay? These are things that are last stage. Like if you're going to use tocilizumab, okay, and I'm going to say this, don't use it on day 70. It's too late. If you're going to use it on day 8, 9, or 10 when you're having the peak within 24 hours of the cytokine storm. The cytokine storm is that week 1, week 2 when it goes really up and then starts going, you know. Use it that time. Don't wait till 14 days or 15 days, because when you get to use it in those days, it's too late. You know, if you want tocilizumab to be effective, use it on day 8, 9, or 10. So those are some thoughts. What else? Dose and duration of ivermectin. I use a 12 milligram twice a day, empty stomach, early morning, with nothing to eat or drink for 2 or 3 hours after the tablet, and a repeat one at 4 or 5 p.m. If they have lunch at 1 or 2, then you do 4 or 5 p.m. Nothing to eat or drink till 7 or 8 p.m. And then you can go with it. You can drink water, but no coffee, tea, juice, no snacks, no food, nothing of that sort. Okay. Duration is 2 days. I don't go beyond 2 days. I don't give ivermectin after day 9. So patient comes to me at day 10, no ivermectin. It's straight anti-inflammatory, anti-clotting. I haven't seen any bad results with the strategy I've adopted. I also do one more thing, the in-room quarantine. I call the patient out of the room and say, you can mix with the family day 10. Day 9, 10, I kind of bring them out, or 24 hours after the last dose of ivermectin. Haven't had a problem with that. So ivermectin seems to work very well. And after day 9, I've never had a problem of the viral, transmission to somebody else in the family. I also treat the whole family, by the way. I treat the whole family at the same time. So prophylactically treat the family. I assume that if the patient has got the virus, and is positive, that the rest of the members would be anywhere from 1% to 99%. So that's how it is. Okay. Do I use a place for hydroxychloroquine? No, I've never used hydroxychloroquine in any patient. Personally, I've used it in the month of February and March last year. I moved to colchicine from 1st of April as my prophylaxis, and vitamin D. My big talk is always on vitamin D, and we just.
Vitamin D, how much? What's the dose you give for vitamin D?
I personally use vitamin D. I keep mine, and as prophylaxis, I tell people to keep it at above 60 and less than 100. I keep mine in the 90s. During acute COVID, I may give a 600,000 injection in the first week and repeat it again 3 days or 4 days later. Along with an iron, I see a V-shaped recovery with the tool. So again, a lot of it is about stimulating the bone marrow, trying to get things up and running and see. These are all trying to get the right word, empirical methods to stimulate the bone marrow and see what happens. But they seem to work. My pharmacologist friend says it's a good strategy, so I stay with that. So again, depends again on how the patient is recovering, not recovering. You try to do what you can do to make them recover. At the end of the day, I'm a clinician. I'm not a scientist. Okay, I make observation. I go back to some of the specialists. I'm a clinician to the core. I will do what is right for the patient to make the patient recover. Okay.
Don't you give oral vitamin D? You give only injection?
I give injection. I give oral when I can't get a nurse or a doctor to do it. If it's in a different city, in Bombay City, wherever it is, I can go myself or arrange a nurse. And again, it all depends on what my arrangements are. If I give oral, I give 60,000 units every day for 10 days, 7 days or 10 days, and then once a week after that. So yeah, we can use orals. I do give orals with fresh lime juice. Early morning, squeeze a lime in a glass of water, dissolve the sachet, or give it with a tablet. The absorption seems to be better. That's what I've been told by the pharmacologist. So again, a lot of things I do which are different from the normal way. Okay. Zinc and vitamin C don't change clinical outcomes. I openly tell people, whether you take zinc and take vitamin C, don't even bother. I mean, nothing's going to happen. You're not going to change the clinical outcomes. Zinc, be careful. Zinc is one of the potential reasons for mucormycosis. We've had a lot of zinc being used in this, at least in India. And one speculated reason could be the thing of zinc. Zinc tends to support the growth of fungus. So you may want to be careful of the amount of zinc you're using. What's the other thing? Zinc and vitamin C is common. I mean, vitamin C, give it or don't give it. You can give them lime juice, fresh lime juice. It's easier rather than giving them vitamin D. So vitamin C. But if you have to give vitamin C, give vitamin C. It doesn't matter. It does not change the clinical outcomes. Vitamin B12 does not change the clinical outcomes. I'll tell you what changes, what doesn't. The only thing that changes is vitamin D. The only thing I'd give during an acute phase or prophylactic phase would be vitamin D. Okay.
Yeah, one question.
There are some evidence of fluvoxamine antidepressant. You never tried, I believe. Did you?
I haven't tried fluvoxamine in acute COVID at all. I've tried to use fluvoxamine now in a post-COVID, post-1 month case with continuing headaches. Has done well. Okay. But again, that's combined with colchicine and dexamethasone. So it's a 3-drug strategy in the post-COVID case because she had a lot of headaches. Her headaches are pretty intense. And I waited 10 days before I started fluvoxamine. It seemed to have made a difference. And again, I'll see her in the third month now when she comes back for the monthly follow-up. Okay, but I don't use. I started using drugs. I've had a strategy. It's a winning strategy. I don't chop and change. I try to do what's required for the patient. Again, based on a very solid strategy that I've used.
Is a guideline difference? The Indian guideline. Do you have a guideline? Or is it different? But whatever you are practicing, is it very different from what the government health ministry of India says?
The government health ministry has had stuff. They've taken 6 to 9 months to change their guidelines. They're now coming around. They've come around to the enoxaparin usage. They finally acknowledged that this is a clotting disease. A lot of changes in the guidelines have come about. The earlier thing of saying take paracetamol and take vitamins and stay at home or stay in the hospital, that's over. Those days are over. Now people are treating upfront. So our rates of post-COVID issues are probably pretty low because many of us do treat upfront from day 1 or day 4 or 5 or whenever the patient comes to us. Okay, so guidelines are always behind what you're doing. We are clinicians. Okay? We are the people who drive the evidence for the guideline change. Okay? WHO and all are the bodies who should be making these changes, but they are too far behind the times. So just the practice what we do. Yeah.
You have already mentioned this to avoid the post-COVID problem. So you think it's aggressive initial treatment can prevent the post-COVID problem? Is that right? So any particular drugs we can suggest out of?
Aggressive treatment upfront, day 1 to 14, prevents a patient from having post 6 months problems. I haven't seen any of my patients today over the last year and 2 months come back to me with post 6 months problems. Okay, they've come back with month 1, month 2, month 3, month 4 problems. I've never seen somebody beyond 6 months continue the same problem. Okay, I also haven't had too many people come back to me with month 7, 8, or 9 from other people's practices. So there's something that we are doing right in India, at least, that is preventing those long haul COVID problems. Okay, initially the guys who had just paracetamol and zinc and vitamin C and vitamin D, those guys came back month 1 and 2 and 3. They came back with lots of problems. I see a certain percentage of my patients will have problems month 1, month 2. Very rarely it'll go on to month 3. So when I treat, I'm prepared to treat first for the first month, then for the next 3 months, and then for the 6 months. So it's like, it's in chunks. Tell the patient, you can expect to get treatment for 1 month. If not 1 month, it'll be 3 months. If not 3 months, it'll be 6 months. So they are mentally prepared for that treatment. So there's no surprise. And explain to them that they can have long-term issues, long-term organ issues, if they don't follow and comply with the treatment. So the West has had a lot of long-term issues, both brain and other organs. So you want to be careful on those things. Okay. I missed something. I was going to say something which I lost out. Yeah. Tell me, sir. What's the next question?
Some more question, I think, Vishnu. Vishnu, there are some more questions, I believe.
Yes, there are a lot of questions. I don't think we can entertain all the questions.
As there are no question, only I started asking. If there are, you can select one.
Yeah, there are some questions. One question is a sequence of devices for oxygen support, like Venturi, rebreathing mask, and CPAP. What do you follow?
I don't. I'm a home-based telemedicine specialist. I'm not a hospital-based, so I cannot comment on that. The hospital physicians are different from what I do. I do a family physician, home-based telemedicine treatment plan. And my admission rate is very low, so I really don't get involved in what happens and when on the oxygen, from the device-based scenario. There's a question about
Yeah. The other question also, of course, I would like to also ask the question. We know that there are the deadly outbreak of mucormycosis in India. So in your practice, what is the kind of incidents you have seen the patient with
Zero.
mucormycosis?
Zero, because
Yeah, I
I
know.
don't use
You are not
steroids. I don't use steroids.
Yeah, I know.
The commonest cause
Yeah,
of
you're
that is
using it as
steroids, diabetes, or immune suppressants, immune compromised patients, diabetes, steroids, and dirty water in the oxygen that's put, and zinc. So there are 4 or 5 speculated reasons. Nobody knows what is the real cause of it. But funguses, I mean, black mold is available all over. Black mold, white mold, yellow mold is all, it's in your bathrooms, in your hospital. And so mold is in the air. I mean, it's not something new. The issue is, why does it get into the nose, or why does it get into ENT? So those are things that we've got to look at from the hospital side of things. I mean, if you use steroids, you're going to have lots of problems. I mean, excess steroids, you're going to have problems. You have to expect those problems. So nothing new. There's one more question that I think is the newest one is, come across COVID deaths following complete vaccination. I haven't, and I've not heard of it still. It's too new. Many of the patients have had one vaccination complete, and then they've had maybe the second one. They come to me day 7, 8, 6, 7, or 8 after the vaccination. Usually they pick it up either at the vaccination center or around the vaccination center, or many people have this attitude that I've become Superman or Spider-Man since I got one jab. And if they've got 2 jabs, they think they're bigger Spider-Man or bigger Superman. They think they can fly. They lose the whole consciousness of the discipline of social distancing and all the wearing your mask and all. I mean, so again, it's more a personal issue rather than a vaccine issue. Okay, deaths so far, no, I haven't had vaccine-related deaths. I haven't had post-vaccine related deaths with COVID. I'm sure there must be some, but again, we don't know what. Here's the thing with vaccine. None of us have a data point to say it reduces your severity by this percentage. I'm sure there'll be trials coming out with data over the next few months that will lay it out. But till now, we all talk about severity of disease will be reduced with your vaccine. But anybody coming to me with COVID is going to get, whether you've had 1 vaccine or 2 vaccines, 2 doses. It doesn't matter. I'm going to treat you as a COVID patient. So for me, it's just the regular COVID treatment, treat it and move on. Okay. Most of them have recovered well. I haven't had to admit a post-vaccine patient to a hospital. So that's all I can say. Okay.
What precaution do you take, Doctor? What you have seen many patients. You have been exposed to COVID. So what kind of precaution do you take yourself?
Precaution I personally take, I wear a mask. If I go to somebody's home, I'll wear a mask. In my home clinic, very rarely will I wear a mask. Okay, I don't use a PPE kit. I don't use gloves. I've used a strategy of deliberately exposing myself with a high vitamin D and colchicine, daily colchicine. So far, my antibodies, I've seen my antibodies go from 0.06 in last May all the way up to 1.16 the day after Christmas. So 26th December, I hit a 1.16, which means you cross the barrier and you're reactive now. And my last antibody test done 15th of May showed a 10.88 something, 10.8 number for antibodies. So it's been a deliberate exposure to patients. I normally would recommend ivermectin for somebody who's very actively traveling or seeing patients. In my own case, I've taken probably 9 tablets of ivermectin over the whole year. So I've never, unless I've overseen patients, seen too many patients for the day, I will take an ivermectin. Otherwise, it's been, I've been pretty good at what I do. And so far, it's been good. I try to stay safe, but I do home visits. I've done a lot of home visits, over 120 home visits to patients. I do see a lot of patients at home in my home clinic. But again, you've got to still take the precaution and still make sure you're protected. So I do wash my hands, and I make sure I'm not, I'm not, I wash my face, I wash my hands, the usual things you do. I don't use a sanitizer. Lots of little things I don't do. Okay. What else? The virus is not as bad as what people make it out to be. The disease is not as bad as, and I mean, that's the message to all of you. It's not a bad disease. It's not a thing. You've got to treat correctly and treat early. If you treat early, it's a pretty easy disease to treat. Okay. You'll hear me say this in every video I've done, every interview I've done, every video I've done, you hear me say this. It's very, very strange. I liken myself to any of us doctors. You could take a truck and drive it. I'm trying to think of where's, from one city to another city. Along the way, if you load up that truck, overload that truck, some place is going to topple over. So don't allow your body to get overloaded with the virus. So viral load has to be well controlled, which means don't try and do 16-hour duties, 7 days running. Try and break it up. Try and break it up in a way that you are there for 2 days and not there for 1 day, or different ways of breaking it up. So you allow your body to take care of whatever's in your nose or your throat. Okay, not allowing it to get in and get out. Get in and cause problems. And stay on your protection. I mean, you can take ivermectin, you can take colchicine, you can take your vitamin D. Make sure your vitamin D is very high. If you make sure your vitamin D is high, none of you will have a problem. None of you treating patients will have a problem. Mine, I try and maintain in the 90s. I've had patients who've had very high antibodies, asymptomatic, picked up at 3 monthly COVID antibody testing regimens, picked up on those, and they have very high antibodies, 80, 90, 100, 150, but their vitamin D is also high in the, between 80 and 90 or 95 and all. They have no problems. They have no symptoms, asymptomatic total. So vitamin D is a damn good drug to use. It's more like a hormone. I call it my hormone, not a vitamin. And I tend to tell people, treat it like a hormone. You won't do wrong if you do that, okay? I can keep talking. Tell me, ask me what question you have.
I think we have answered all the questions. One more question. Which you experience out of all the vaccines, what is your preference?
We have 2 vaccines available in the country, Covaxin and Covishield. I've been involved in vaccination camps with Covishield. I do know about Covaxin. I've treated patients who've had Covaxin and had COVID. Honestly, they're both similar. And yeah, they have different modes of action. The objective of both is to induce some antibody production in your body. Okay, so that's some antibody. So once that antibodies are developed, it is to help the body recognize the foreign body or recognize the virus and kind of fight against it. Main thing at the end of the day is your antibodies are your frontline soldiers. You want your B cells and T cells, which are the battalion and tanks, at the back to really support you. You want that developed. So you want your bone marrow to really develop and create those antibodies, create those B cells and T cells so that you have some amount of immunity to reduce the severity of disease. The vaccine is not going to prevent you from getting COVID. It's going to prevent you getting a bad attack of COVID. And still, we don't know what is the level of protection with a vaccine, okay? Ivermectin prophylaxis, yeah, you can use a 12 milligram dose I normally tell people use it every week. Every Saturday morning or Sunday morning, take 1 dose early morning, and your prophylaxis is done. Here's why I say every week. The median time to incubation is 5.2 days. Usually a patient will show symptoms between day 4 and day 6. So that 5, 6, 7 days, if you're doing, it's not a bad strategy to. You can prevent getting really bad COVID if you take the ivermectin on a weekly basis. But keep your vitamin D up. Don't do without the vitamin D. That vitamin D is very important. In our countries, Sri Lanka, India, and all, we can do the injections. The injections is 600,000 units every month or every 3 months. Again, based on your levels, initial levels, is very important to maintain your levels above 60. You get to the 60 plus range, your attack of COVID will be very minimal. You will have probably an asymptomatic or a mildly symptomatic COVID. So don't worry about that. Okay. How long does a natural immunity last? As of now, it's 1 year. As of today, from what the data I'm reading, from the trials I'm reading, 11 months is what they talk about. From the data I follow, and I follow what happened in the US, particularly Boston and some of the major cities, New York, New Jersey, Seattle, California, from December and January, December 2019, January of 2020. I followed those statistics. They haven't had a reinfection in a normal person. Immune compromise, yeah, there's been some. But so that should talk about the immunity. So we are now in July. Let's take January 2020 as our start date. So 18 months, I think we've got established 18 months of protection, okay? There was a study from Lombardy, which is Milan, the Milan province. You know, the Lombardy is called the province. So Milan is a city. There was a study which talked about a 1 year data of reinfection, 1 out of 100,000. So one person was reinfected with COVID out of 100,000 people who were COVID positive, RT-PCR positive. That is an interesting pointer that we will have long-term immunity. I'm personally expecting us to have at least a 2, 5, maybe even longer than 5-year immunity to COVID. So I'm projecting at least a 5-year immunity. Let's see. We don't know. You know, lots of things we don't know. Out of all the strains, what's the worst strain? I don't know what the worst strain is. I've treated, the initial cases were bad. There were times where we saw out of, I'm just using numbers here, out of 21 or 22 cases in the space of a week, every case had lost a male earning member in that family. And it's tough when you lose people like that. You know, the family member of somebody had died already, okay? I've had people who have had diarrhea. There was a strain that came into Delhi where diarrhea was the only symptom, first symptom, and 10, 12, 20 times a day was diarrhea. I mean, that was a strain that came out of somewhere, don't know where. We've had strains coming from everywhere. We had Italy strain, we've had the UK strain, we've had the US strain, we've had the Wuhan strain. The Wuhan strain came because we transferred students who are studying in Wuhan back to Kerala, and that spread around. We've had all kinds of strains. So I think India has gone through the grind on the strains type of it. Now we have what's called the Delta strain, which is an India strain. I think it's a combination of everything, and the Delta plus strain, which in my view, I think we've treated some of these patients already in the last, I'm talking of 4 to 6 months at least. So I don't think there's an issue. What's the other question? Post-COVID syndrome. Let's talk about post-COVID. Okay, post-COVID, after I classify post-COVID as anything beyond 1 month. So you have an acute post-COVID, and then you have a chronic post-COVID. Chronic post-COVID would be after 6 months, okay? And I have not seen a chronic post-COVID beyond 6 months in India. I do get patients from the US, I get patients from Canada, I get patients from the UK, and many in Europe. Europe, I can't treat them, they can't get the medicine. But some of these countries, we can get medicine. I can work with doctors in those countries, and they can get treated. So again, up to 1 year, you can get treatment for post-COVID. The main thing is in the first month, at the end of 30 days to 180 days, so 6 months. Make sure that the lungs are clear. Clean up the lungs. You'll hear me say this statement all the time. My approach in the first month, second month, third month is to clean up the lungs. You get about three months to clean up the lungs. So anybody with a HRCD severity score or a damage, lung damage of 50% or more, try and clean up the lungs. Otherwise, they'll end up with 50% fibrosis, lung fibrosis. You don't want that happening. So you want to really clean up the lungs as soon as possible post-COVID. And again, you don't need to use ivermectin. I use colchicine. Sometimes I'll use dexamethasone, and I use enoxaparin for the post 1 month, post 2 months, or post 3 months treatment. Again, it's all monitored. It's all actively managed, actively monitored. So it's a strategy that has worked for me very well. I haven't had cases remain, let's say, a 50 I've had 15 by 25. I've never had a 15 by 25 remain at 15 by 25. I've had them down at 3 or 4 or 5. And I'm willing to give up. I'm willing to give up 3, 4, or 5, which is about 10, 15% lung damage. I'm willing to give it up because I believe in one thing. Perfection is the evil of good, is the enemy of good. I want a good result. I don't want a perfect result. So I'm not going to go out and out to try and get the perfect result. I try to get the best result, which is a good result for the patient, and move on. You know? Okay, what else? Steam inhalation, hot diet. Hot diet, don't do it. It damages the stomach lining. You will have hyperacidity. It could damage your esophagus, and don't do it. I openly dissuade patients from drinking hot water. I do it. I mean, I'll talk about diet later, but let's talk about steam inhalation. Steam inhalation is good. It's the method to clean up the throat and the lungs, the throat and the nasal passages of any virus, whether dead or alive, mainly dead virus. So if you want a patient to come RT-PCR negative, do the steam inhalation aggressively for 2 or 3 days before that, and you'll be able to get them RT-PCR negative in 2 days. 2.5 days, you'll get them RT-PCR negative. So again, depending on what you want to achieve, you can actually do these steps. What's the other thing? Ventilation, I'm not going to talk about ventilation. So let's talk about general nutrition. In COVID, since it's inflammation of the brain and inflammation of the gut and inflammation of the nerves, it's an inflammation of the nervous system, which the brain loses control of the GI tract. You get nausea and vomiting, and you get diarrhea, okay? That's a common symptom of COVID, okay? So giving them soft foods, giving them soupy foods, anything in soup form, anything with, so let's talk about dal and rice. It needs to be overboiled rice, overboiled dal, to make it really soft so they can swallow it and process it. I try to avoid meats, so no meats during the 14 days, no alcohol, including no cough syrup. Cough syrup contains alcohol. You'll always see, almost in 95, 99% of cases, you see liver enzymes raised, liver being inflamed. Of course, you'll see diabetes, you'll see the diabetics, but you'll see high sugars also. But mainly I see the liver enzyme raised in the first 14 days. That's because of acute inflammation in the liver. So I try to avoid anything that will damage the liver further. So no cough syrups. I use the Budecort inhaler, the budesonide inhaler a lot, especially when you have chronic cough and the cough's bad. I try to use that and kind of work with that, okay? So that's how I kind of work on. What else?
Okay, thank you very much. I think we can conclude the talk now. And
okay.
On behalf
we've gone above time.
Yeah, on behalf of Medical Association, I would like to thank Dr. Darrell Demello for your excellent speech on your current experience about the treatment of the COVID patients. And I hope this is a good eye-opener for us also, because we have learned a lot of new strategies, so we can incorporate into our patients also in future. And once again, and it's the interactive session. I mean, the question and answer session is very interactive and very interesting too. And the attendants were able to ask their questions. Once again, on behalf of Medical Association and President and the EXCO committee, I would like to thank you. And
Gets Pharma also.
Yeah, Gets Pharma to give us the platform to conduct this webinar, and all the participants around the world and from Sri Lanka as well. Thank you very much, sir.
Thank you very much.
Thank you, guys. Thank you, Dr. Sundaresan, Dr. Vishnu. Thank you to all the attendees. I really appreciate the opportunity to be able to share some experience and forward. Good luck to you guys. Take care. Okay. Thank you. Bye.